Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are here discussing APRV with Dr. Palen Mallory. Dr. Mallory, please introduce yourself. Tell us about your academic interests related to today's topic and maybe something you enjoy outside of medicine.
Thanks so much for having me. I'm really excited to be here. My name's Palen Mallory. I'm a pediatric intensivist at Duke University, and I've been there for close to 7 years. My academic interests have really fallen into the airway safety and ventilation category. I'm the Duke primary investigator for Prospect Study, as well as the Duke primary investigator for the Near for Kids Collaborative. And so through those venues, I've had opportunities to pursue airway safety research, quality improvement, and also ventilation research.
Oh, yes. Palen, you've had really a quite productive career in respiratory care research, and you joined from Vanderbilt and went to Duke and have really built a career in this area. What advice do you have for maybe early fellows who are trying to plan something like this, or early career faculty who are really trying to get started?
I would say try to get involved in these multi-center collaboratives as early as you can and as the opportunities arise. That's a really good way to get your foot in the door, to develop connections with people at other institutions, and a lot of opportunities will just almost fall into your lap at times to get involved in multi-center research and have some guidance in your own safety and quality improvement projects.
Wonderful. Great advice. Don't do it alone, right?
Correct.
Join the structure that's already available.
Yep.
Get things going. Before we get to our topic, APRV, any conflicts of interest to disclose?
I do not have any.
Wonderful. Alice, you can give us her case.
Yeah, let's do it. We've got a 17-year-old girl being managed in the PICU with ARDS secondary to bacterial pneumonia. On day 1 of intubation, she experiences worsening hypoxemia despite following the ARDS-NET PEEP FiO2 table requiring high FiO2. Despite this, she is hemodynamically stable, experiencing no difficulty with ventilation, and awake enough to nod yes and no to questions. The team is considering converting to APRV. Palen, what exactly is APRV, or airway pressure release ventilation? If we were your first year fellow and you're like, it's time, we're converting this patient, how would you explain it to us?
So APRV is also other ways you might hear people talking about it is bi-level ventilation or bi-vent, depending on the type of ventilator that you're using. It's a ventilation mode that's been in use really since the 90s and was first described in 1987 by 2 physician scientists, Christine Stock and John Downs. And their initial description of APRV was that it was a new way to administer simultaneously a supportive level of CPAP, but also assist in carbon dioxide elimination. And it can really be described as a time-cycled, pressure-controlled, intermittent mandatory ventilation mode. And it has a prolonged, sustained inflation, or you can think of it as a high CPAP level with an extreme inverse I to E ratio. So you have these brief cyclical releases to provide some CO2 removal. And when you set it, it typically results in about 8 to 10 releases per minute. They're very brief releases. Those are time-triggered mandatory breaths, essentially. And then on top of that, the patient can spontaneously breathe in an unrestricted way anytime during that respiratory cycle in between those mandatory breaths. And this is thought to be perhaps a more comfortable way to maintain spontaneous breathing during mechanical ventilation when compared to, say, SIMV. And so your CO2 removal occurs via those spontaneous breaths and also during those release phases from that higher CPAP level. The general idea is that when you ventilate a patient this way, it can provide open lung ventilation in a way that can increase your mean airway pressure and improve oxygenation without necessarily further increasing your peak inspiratory, your peak airway pressure. Doing this, you can maximize and maintain your lung recruitment while minimizing barotrauma and also just allowing unrestricted spontaneous ventilation.
For a first-year fellow coming to this for the first time, I feel like what's most apparent when you walk into the room and see a patient on APRV is the inverse of where the patient spends their time in the respiratory cycle. We always think of a patient spending much longer in exhalation than inspiration. Mm-hmm. And that is so apparent. You're going to walk in there and instead of your patient who's really sick on a respiratory rate of 25, 28, they're going to be in a respiratory rate of what looks like 8 or 10. And they're going to be getting these so long breaths in, and they're going to be held for a longer period of time, and they're going to have a really quick exhalation. And when you think about, what determines your mean airway pressure, of course, it is your inspiratory pressure and expiratory pressure, but your inspiratory time is also in part of that equation. Is we have these patients with long I time maintaining their inspiratory pressures, spending lots of time at that higher pressure. It's really going to help their mean airway pressure and oxygenation. So you reviewed for us some of the advantages of this, maintaining lung recruitment, helping oxygenation. What disadvantages might this offer some of our patients in the PICU?
Yeah, so I'll talk about maybe a few more of the advantages because that can then tie into some of the disadvantages
too. Because there are advantages. Yeah.
So we talked about the lung protective recruitment and that there are fewer of these inflation-deflation sequences occurring. The high mean airway pressure is really maintained via that long time high, and there is less volume loss of the lung if it's set correctly, which we can talk about, of course. There's less volume loss during ventilation, ideally, so that you have less de-recruitment during those brief exhalation phases. And so ideally, all of this leads to less trauma from atelectasis via less alveolar microstrain. The unrestricted spontaneous breathing can impart some benefits. It's thought to be a more comfortable way to breathe, so there could be less issues with dysynchrony when you compare to conventional mechanical ventilation. And this spontaneous breathing, maintaining that can maintain diaphragm function during that period of critical illness. And also, it's thought to perhaps better ventilate the dependent lung areas. And this has been shown in some animal models that this will decrease your dead space and overall, hopefully improve your VQ mismatch. Several studies have compared conventional ventilation to APRV use and how it affects hemodynamic function when mechanically ventilated. And there's been no studies that have shown that APRV has a deleterious effect on hemodynamic function. In fact, it may have a beneficial effect on hemodynamic function and cardiac output and lead to less vasopressor and inotrope requirements. And that's thought to be, again, secondary to the spontaneous breathing and improving venous return. A further benefit is reduced use of sedation. Because spontaneous breathing is so important to making this mode successful, most often the patients are not paralyzed. And because the pattern of spontaneous breathing may be more comfortable, use of APRV has been associated with less sedation use, which of course has its benefits with reducing rates of delirium and other side effects from prolonged sedation. And then lastly, when we talk about airway clearance, some studies have found that airway clearance could be enhanced or maybe more effective in patients ventilated with APRV, probably again related to more wakefulness and spontaneous breathing. So they have a more robust cough and ability to clear their own airways. But that brief exhalation phase produces a high expiratory flow rate, which may aid in mucus clearance. So some studies have found that APRV use is associated with lower rates of ventilator-associated pneumonia. So I think it's important to think about those benefits because then when you think about the concerns about APRV, there are pro and con arguments to all of those things. So one of the biggest concerns that many have is that there's a lack of familiarity with its use. And it's really important to achieve this balance somewhere between hyperinflation and de-recruitment of the lungs. And if you don't know how to set APRV, and if you are not vigilant in following changes to the lung properties that then require you to maybe modify those settings, that balance between hyperinflation and de-recruitment may not be achieved, and then you run the risk of inducing lung injury. And so the lack of experience by clinicians, both physicians and respiratory staff, and that's very center dependent, but that lack of familiarity definitely could lead to more harm than benefit from APRV use. There's also a lack of consensus to guide how to set it, how to titrate it, what patients are the ideal candidates for it. And so then that ties into the benefit that could potentially come from using APRV is taken away, right? When you have people who don't have expertise in that ventilation mode running the ventilator. Another concern about its use that has been brought up in literature is that there could be wide variability in lung volume when you think about the combination of those release breaths and the spontaneous breaths. There could potentially be large tidal volume swings and variability that's a bit hard to monitor and measure. And so that could lead to volume trauma. So we talked about how in the benefit category, it could provide more lung protective ventilation, but there's also a concern about the variability in lung volumes that could actually take that benefit away or negate that benefit. Also, there's been more focus recently on lung injury related to work of breathing during mechanical ventilation. And the spontaneous breathing is such a large component of APRV use. And when a patient with ARDS takes these strong spontaneous breaths, that generates more negative pressure that could create high pleural pressure gradients, and that could worsen lung injury at a time when the lungs are already sick. So while spontaneous breathing has its list of benefits that we talked about, it could also potentially worsen lung injury. And then if a patient is in shock or has poor oxygen delivery, those spontaneous breaths, the diaphragm muscles have high oxygen consumption. And so that could worsen oxygen delivery in settings of severe critical illness and shock. Lastly, this is tied into that balance I was talking about with avoiding hyperinflation, but also avoiding derecruitment. When you have these heterogeneous lung units and along with ARDS that may have different time constants, some are going to be filled more than others, some will collapse more readily than others. And so there could be lung injury related to atelectasis that occurs just because that lung inflation is a bit harder to control. And we can talk a little bit more about that when we talk about the different ways to set APRV.
Oh, absolutely. Palen, is it safe to say that APRV is almost a way of doing more by doing less? You let the patient breathe over their pee high. You let them exhale maybe half a second every 5 seconds, just a little bit. And as long as you're monitoring closely to make sure that those P low and T low times aren't so long that they're getting atelectasis back, you're kind of just keeping their lungs maximally inflated and leaving them alone. Is that a way to think about it?
Keeping their lungs inflated is a good way to think about it, but you definitely don't want to leave them alone because as the lung physiology changes, you're going to have to start adjusting, especially that time low, because that will affect the volume of air that's expelled during those release phases. And that's really important to pay attention to that, especially if your P low is set at 0, which is one of the methodologies that has been published in literature. You have this P low of 0 with a very short T low, and you end up relying on the creation of auto PEEP to maintain your lung recruitment during those release phases, as opposed to setting a higher P low and a longer T low. And so you really have to know which of those setting strategies you're using and how to monitor that lung deflation period so that you're not de-recruiting every time that you have a release.
You've already reviewed for us that the best patients for APRV are those who don't have significant shock, who maybe don't have like severe work of breathing and perhaps have that spontaneous respiratory drive. What would you say would be like the classic patient or the best patient you think would be best suited for APRV?
Well, I think the patient in this case that we discussed could potentially be a good patient, a patient with primary oxygenation failure who is perhaps old enough to be awake and be able to tolerate having a breathing tube in place and being in the ICU. You think of your younger kids, you certainly have younger kids who can do that, but most of them will require sedation just for safety reasons. And so, especially your younger kids, the need for sedation at potentially higher levels could affect their spontaneous breathing effort. And as we've talked about, the spontaneous breathing is such an important component of this that typically I think your older children might be the more successful age group to use this in. Patients that it may not be a good ventilation mode for would be your patients, of course, with asthma, because you need very long exhalation phase for that. So that would really be a bad population to use this in. And then your patients that are requiring a lot of sedation for other reasons, like a patient with traumatic brain injury or status epilepticus who are requiring sedation for ICP control and seizures, that's going to take away their spontaneous breathing ability.
They need to be able to benefit from keeping their respiratory drive and using it, and also benefit from the fact that they can maybe stay awake and engage with the rest of the room and things like that during APRV, where a lot of the high, even straight high ventilator settings, you would need them sedated enough to really work with the ventilator.
Yeah. And, we know now that there are so many benefits associated with less sedation use and being able to engage in physical therapy while you're intubated and ventilated. And we have kids sometimes get up and sit in their chairs and maybe even walk around while they're ventilated. And so this may be a mode that may help facilitate some of that happening just because of the improved ability to be awake.
It's not something that I thought about, but APRV perhaps could help facilitate reducing the risk of delirium. But in that patient who is delirious might not be a great candidate for APRV if you're having to sedate them more.
Yep.
So it can be a bit of a tight spot there.
Yep.
We've talked about how patients with hypoxia tend to do better with APRV, but maybe not as much for hypercapnia. Will you tell me more about the advantages, disadvantages of using APRV for a patient who also has significant hypercapnia or respiratory acidosis?
Yeah, I don't think, most of the literature looking at APRV is really focused on patients, adults and kids, with oxygenation failure being their primary problem. Of course, a lot of those patients will have ventilation failure too. I think it's going to be variable depending, again, on the patient's ability to work with the ventilator and spontaneously breathe, because the drops, those release phases, are not enough to fully ventilate the patient, especially a patient who has hypercarbia from ARDS. So they really have to provide that spontaneous breathing effort as well to be able to appropriately ventilate.
So maybe less of a strict contraindication like an intubated asthmatic would be, but if it's a really strong kid and you could give it a short trial, see if they could generate the minute ventilation on their own, and then if they can't.
There are several studies out there that show that transition from conventional ventilation to APRV improves oxygenation within the first 24 hours of that transition. But there really haven't been many studies looking at specifically the CO2 levels in those patients.
I mean, I think it's really easy to see how you would get, at least for a short period of time, a worsening ventilation. You think about minute ventilation is your respiratory rate times your tidal volume. If you're taking a patient who was breathing in the upper 20s on the set rate, and then now you're putting them on a set rate of 8, maybe less, by definition, you're going to have less minute ventilation there. You do hope that they're having the spontaneous respirations on top of that, but they're probably not as large as those release volumes, which hopefully are 5 to 8 mLs per kilo. But on the other hand, if you do recruit more lung and you have more functional lung units, you would think your ventilation would get better over time as your VQ matching improves.
Yep.
So I wonder if there's a pitfall there of, we gave APRV an hour, the CO2 keeps going up. We failed, right? And I wonder if that's probably not the right answer.
Yeah. And, the sort of gut reaction to inappropriately high CO2 levels would be to create more release phases, right? Yeah. And shorten your time high, which you can certainly do and should improve your CO2 number, but that's going to be at the expense of your mean airway pressure. So you need to just take that into account when you are thinking about adjusting that to create more drops. Eventually, you might have to create so many drops that you might take away that mean airway pressure advantage that you're hoping to gain from use of APRV.
Yeah, absolutely. Another one of these relative contraindications is the use of paralysis or a patient who's requiring paralysis. We were talking before that on every non-conventional mode of ventilation, there are beginner moves and advanced moves, and I certainly have had paralyzed patients on APRV in DC. But how do you think about this? Especially because our intubated ARDS patients, they may need a dose of paralysis, right, for retaping their endotracheal tube. Like they may need here and there.
Yeah, using that intermittent here or there paralysis dose, I don't think should dissuade someone from trialing APRV if they think they have the right patient. I don't think that the right patient would be someone who required paralysis, on an infusion long term. Just because, again, that spontaneous breathing provides such a large percentage of your CO2 clearance. And if you take that away, you're going to have to modify your settings in other ways to make up for that. And like I said, that will typically be at the expense of the mean airway pressure.
Yeah. And the benefit is that you don't have to paralyze them. And then if they are, then why not just use? Yeah.
Maybe a side point here. Gosh, I hate it when we have to give paralytic for ET tube retaping. I wish we would just
listen.
Wish we could better sedate these patients for these procedures.
As I was saying, and I heard it.
Yeah,
that's a conversation with our perfect PICU nurses.
Yes, that's right.
Yeah.
I think that's pretty institution specific. I've worked one place where everyone got paralyzed for tube retaping no matter what, and then I've worked other places where it was really a case-by-case basis, and we don't necessarily paralyze every patient who gets their tube retaped.
Yeah. And it's also unintended extubation is such a quality metric that different units focus on in different ways that you can't, my one recommendation there is you're going to a new institution. I wouldn't shake that culture too much right when you walk in, right?
Correct.
Because everybody, it's nursing licenses, it's unintended extubation, it's the number of hands people have available. In a perfect world, we would never have to, but yeah.
I think it's unfair when we tell our nurses and RTs, here's a dose of fentanyl, go retape the tube. Because it's not particularly, it might be some pain to the procedure, but it's not a very painful procedure. I bet it's very anxiety provoking, right? And I feel like our patients need real sedation. And since we're officially on this tangent, I feel like a dose of propofol usually does so much better than a dose of fentanyl, et cetera. But, as we close this tangent, anything else to add?
Yeah. But who pushes it, right? Do you have a PICU fellow? Do your nurses push it? It's so cultural.
Problem.
Yeah.
Yes.
Yeah.
Where are we, Alice?
Sorry. Back to APRV. Okay. Palen, to take it back to respiratory physiology, the perfect patient for APRV, as you've been outlining for us, has classic ARDS with a low airway resistance and low compliance. If you multiply resistance and compliance, you get the time constant, and these patients, therefore, have a short time constant. Why is this so necessary in APRV? And why does the fact that time constants vary between alveolar units matter?
So if you think about those release phases where you have a large amount of your CO2 clearance occurring, you have a drop from your P high to your P low, which may be set at between 0 and 5, depending on what methodology you're following, but say 0. And that release phase happens very quickly over, again, depending on the methodology you're following, anywhere from like 0.2 to 0.8 seconds. So if you think about releasing the lung volume over a 0.2 to 0.4 second time frame, you need a pretty high rate of airflow to occur to really benefit from lung volume release and CO2 clearance. And so the time constant plays a role in your ability to produce airflow out of the lung. And if, again, you're not trying to remove air completely from the lung, right? Because you don't want to create atelectasis and lung collapse that you then have to re-recruit with your next breath. If you have alveoli with differing time constants in areas of the lung that are heterogeneously ill, like you do in ARDS, some of those areas of the lung will empty at different speeds than the others. And so you could potentially get inflated and deflated areas of the lung. And ideally, what you want is more homogeneously inflated areas of the lung to maintain your lung volume during that expiratory phase.
Mm-hmm. So maybe the sicker alveolar units or the alveolar units more affected by the pneumonia in the patient we gave you will have shorter time constants and be more prone to repeated atelectasis when you're at the T low and the P low compared to the less affected parts of the lung.
Yes. And this factor idea really plays into the importance of knowing what you're doing when you dial in the settings and how you monitor the patient during that.
So another way we think about APRV is maybe better for older kids. Is it possible that the inadequately developed collateral ventilation, sort of the lack of those pores of Kahn between alveoli or canals of Lambert in children under the age of 2, children under the age of 5, makes this a worse mode of ventilation for them? Is it possible that it's just worse for toddlers and infants?
I think in theory, yes, that could be a concern. I don't think that's been really proven in any studies, of course. But again, that collateral ventilation helps to maintain more homogeneous lung inflation during those exhalation phases. And that could overcome your difficulty with the areas of different time constants that could improve the distribution of lung volume, essentially, especially during that exhalation phase to help maintain your lung recruitment during the drops.
So up to this point, we've talked a lot about the theory and rationale supporting why we would use APRV. I wanted to get to what clinical evidence we have. And, as someone who is relatively a novice to this setting, I see that there's some issues here with just familiarity, like big picture of many institutions, and probably variability between how people implement this. So what clinical evidence do we have in the literature that can support us in using this for our patients?
Yeah, so I'll talk about, as always, most of the studies have been performed in the adult population. And so in pediatrics, we are stuck with either extrapolating adult data or taking our data from much smaller populations of patients or case reports and observational studies. But there have been a few in APRV, even in the adult literature. The adult literature is not robust, and there's nothing really supporting its use or supporting its disuse in ARDS patients in adult ICUs. But there was a meta-analysis done in the last few years that looked at 5 randomized controlled trials in adults, and it included 330 patients. And overall, APRV was associated with an increase in ventilator-free days, a shorter ICU stay, and a lower hospital mortality with no increase in adverse effects like cardiovascular hemodynamic changes or barotrauma. So there was a potential benefit in lower hospital mortality with APRV use, but a major weakness of this meta-analysis was that they're comparing APRV strategies amongst 5 different studies, and people initiate APRV at different times during the ventilation course, or they set it differently. And so it's really hard to take those 330 patients as one homogeneous group and compare them to low tidal volume conventional ventilation and really be able to adequately compare them to get good answers. So 2 of those studies that were included in that meta-analysis randomly assigned patients to low tidal volume conventional ventilation versus APRV pretty early in the ARDS course within the first 48 hours. But they set the APRV differently. One set P-low and T-low differently. So it's really hard to compare those methodologies. One study by the author Zhao found that early use of APRV in ARDS compared with the low tidal volume was associated with improved oxygenation, like we've talked about, and shorter ICU stays. Another one by the author Varpula compared 58 patients, and they actually terminated the study when they were 2/3 of their goal number for futility because there was no difference in their primary outcome, which was ventilator-free days. So again, nothing convincing in the adult literature one way or the other. Like I said, in pediatrics, our understanding of the use and effectiveness of APRV is much more limited than that. It's really limited to case reports and a few retrospective observational studies. In 2018, the first and, as far as I know, only randomized controlled trial in children was performed at a single center. Primary investigator on that study was by the last name of Lagudi, and they enrolled 52 patients, and they compared APRV with low tidal volume conventional ventilation in children with ARDS. And the APRV group had higher mean airway pressures, greater spontaneous breathing, and early improvement in oxygenation, which we would expect given what we know about APRV. There were equivalent safety outcomes between the 2 groups. So they looked at things like air leak, because that is a potential concern with APRV use. No studies have found that more air leak is associated with APRV use, which is good to know. The baseline characteristics of their 2 groups were a bit different. So despite randomization, the APRV group did have more severe lung injury and higher oxygenation index at the time that ventilation was initiated. They also differed in their rates of primary versus secondary lung injury between the two groups. But overall, they actually terminated the study early, given higher mortality rates in the APRV group. And when they adjusted for some of those baseline characteristics, that mortality rate became less significant, but there was still a trend toward harm. Mm-hmm. So the study was terminated. So there certainly, from what we have in pediatrics, there certainly is nothing out there that should convince anyone that APRV could provide a survival benefit, a meaningful benefit for a meaningful clinical outcome.
Oh, absolutely. And we'll certainly link your reviewed article and those papers in the show notes because that is important to consider.
I mean, it's so hard to describe a ventilator mode causing a survival benefit, right? Like we know that 6 per kilo tidal volume is better than 12 per kilo tidal volume. Mm-hmm. But we don't know if it's like 6 versus 10, 6 versus 8. Mm-hmm. And then to try to find a way to show that this one mode of non-conventional mode of ventilation is better than the conventional. We have issues with patient selection. When do you start these patients on this therapy? Site familiarity, and then like inter-site differences in how they set these things. It's a complex question. I would imagine that because of the lack of robust evidence, people who don't have lots of familiarity with this mode, they just tend to lean towards what they know really well. And, in those sick patients, that's probably not the time to experiment quite a lot. That's probably the time where how effective you are at dosing your ventilator and titrating those therapies probably matters the most. So I see there's a pretty high barrier I would feel for a lot of PICU clinicians who don't have that experience from adopting some of these strategies. Does that tend to make sense?
Yeah, especially in a high resource setting like we have. APRV is classically used as a rescue ventilation mode, similar to how most of us use the oscillator. We use it when what we're doing on the conventional ventilator isn't working anymore, and we are on what we would describe as maximal support on the conventional ventilator. It's not working. Of course, Prospect is hopefully going to help answer that oscillator question for us. But both of these modes are thought to be rescue modes. One of the big questions out there is, should APRV be used more as a primary ventilation mode? Of course, we don't know the answer to that, so we certainly can't endorse it as a primary ventilation mode right now. I think one population that we should consider its use in is populations with lower resources who don't have ECMO as a rescue therapy, or maybe who don't even have the oscillator as a rescue therapy. I could see a benefit in increasing familiarity of its use in those sorts of settings for sure, because why not have some sort of alternative rescue mode that could potentially provide a patient with some benefit?
And it's the same ventilator a lot of times, right? Mm-hmm. So I mean, you don't have to do this big transition.
Yeah.
I guess to the point of it's really hard for a unit to change its rescue ventilation culture because these are the kids that you're worried they're about to have a cardiac arrest, right? Like you're not about to mess around on them. But at least at APRV, if you were going to use it, I would be hard pressed to paralyze and oscillate an infant that doesn't need that. But you don't have to paralyze if you're transitioning to APRV, and you can theoretically do it on a less sick patient.
You can use it on the same ventilator. There's less risk of hemodynamic effects compared to the oscillator, I would think, and you don't need to paralyze. And so it certainly is less of a big change, if you will, if it's the right patient.
Oh, wonderful. And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.